I believe that presently the most important clinical issue that is underappreciated is the relationship between the insertion of the central venous catheter and the care and maintenance of the device. The proper insertion of the central venous catheter is vitally important and has been well studied in the literature and videographically over the past 70 years. Care and maintenance has not received the same attention, and the relationship between the two is rarely, if ever, discussed. Temporally speaking, a central venous catheter takes between 30 and 60 minutes to insert if one considers all aspects, including disposing of the waste and composing a procedure note. Once the dressing has been applied, by definition, the patient enters the care and maintenance phase. The duration of care and maintenance lasts 6 days on average, and frequently far longer. The 60 minutes of the insertion, divided by the 8,600 minutes of the care and maintenance, indicates that the insertion phase is less than 1% of the life of the central venous catheter. The insertion, though quite important, is temporally insignificant in the overall life of the line. Considering the overwhelming temporal dominance of care and maintenance, it is clear that a vital component of a proper insertion is to hand over the central venous catheter to the RN in a manner that allows for optimal care and maintenance. It must be realized that central venous catheters are nursing tools. A central venous catheter that is handed over in an improper configuration related to care and maintenance is a classic representation of the silo mentality that is rampant in modern medicine. If preventing infection is the goal, then the CVC must be inserted in a manner that permits ideal nursing care. The teamwork required between the inserter and the RN must be emphasized as a primary objective. I will list a number of insertion recommendations that will improve the care and maintenance and patient outcomes. My first recommendation is use ultrasound guidance at every insertion. Second, the optimal location for the dressing is the chest. Third, I recommend using the following 3 techniques to position a dressing on the chest, which is a flat surface. Number 1 would be to directly puncture a vein on the chest. For example, the axillary vein. When you use ultrasound, it's the axillary vein and not the subclavian. The other way to do it would be to get a dressing on the chest would be to puncture the internal jugular vein low in the neck and rotate the catheter downwards. The third way would be to puncture the internal jugular vein low and tunnel the catheter into the infraclavicular region. We have to avoid the internal jugular vein placement that is directed upwards because it's very difficult or impossible to have a proper dressing when that configuration is used. Another recommendation is to use micropuncture technology. It's just better. I don't incise the skin unless I'm making a tunnel. The skin is the natural barrier to infection, and I try not to damage it with incisions or sutures as much as possible. I like to use antimicrobial catheters and antimicrobial dressings, and I think there's good literature support for both of these devices. I use sutureless securement. I haven't sutured a catheter in 14 years, except for extenuating circumstances. I strongly believe in the use of a dressing adhesive to help the dressing stay on for 7 days. By convention, we change the dressing at 7 days, so we want to let it stay on for that period of time. A dressing that's disrupted just exposes the patient to the toxic environment of the intensive care unit or the general nursing floor, med-surg floor in general. Finally, my last recommendation for now would be to use ECG-based tip location technology. This technology will allow you to determine during the procedure whether the catheter is going in the right direction or, more importantly, in the wrong direction, and you have the opportunity to fix it while you're still sterile. This is an evidence-based technique that should be much more widely used in the United States. In the fictional Why Hospitals Should Fly, John Nance states that the most dangerous words in the English language are, because that's the way we've always done it. I would like physicians to have an open mind and realize that there is an alternative way to perform central venous access. It is different than the way they were trained. Hopefully, the physicians will see that the described techniques have merit. At that point, it will be a matter of standardizing training and getting the right equipment into the insertion and maintenance kits.